Hello everyone, I'm Susan Cole.
And I'm Dr Vanessa Apea.
And welcome to Rooted and Rising, the live broadcast series focused on the health inequities affecting Black women and, crucially, steps that need to be taken to fix the inequities we faced once and for all. I'm thrilled to be joined by two phenomenal guests, hopefully two, because one of our guests is having a few tech issues, but I hope that she's going to be joining us, and that is Yvette Raphael, one of South Africa's most influential civic leaders and human rights activists and co-founder of Advocacy for Prevention of HIV and AIDS. She's an internationally respected leader in HIV prevention and has spent more than 2 decades shaping research, policy, and advocacy with a particular focus on ensuring that women and girls are at the center of the HIV response.
Indeed. And so fingers crossed. And also we have the wonderful Dr Melvina Woode Owusu, who is an Honorary Associate Professor at UCL's Institute for Global Health. And she is also the founder and director of Purple Pen Research and Evaluation Consulting. And Melvina's work, which I know really well as well, focuses on addressing the inequalities that are experienced by Black communities, and also particularly ensuring that community knowledge genuinely shapes research, services, and policy. So really excited for them both to be here and crossing everything.
Absolutely. So I've recently come back from Rio.
I know. I've tried. You know, it's awful because I was saying to Susan that every time there's a conference in a beautiful place, I say I'm going to go, and then something happens and I missed it, and I was devastated and I was very jealous. So I'm looking forward to hearing all about it.
Well, I was the lead rapporteur for
Indeed.
the community and leadership sessions. Which sounds quite glamorous, but the reality was I was working every evening writing up the reports until like midnight, many days, eating crisps in my room for dinner when other people were out partying.
Indeed.
But I did have a couple of nights out, but it was an absolutely extraordinary learning opportunity, and I would feel really privileged to have been in that role and also did that work. But what really stayed with me was something that someone said in one of the sessions that was covered, which was, every time we turn around, something is being taken from us. And it was really shocking to hear about the impact of all of the cuts that we've seen across the HIV response, and particularly the impact that was having on Black women. And this wasn't just something that we're seeing in a few countries, it's just something that we're seeing across the board, even in the USA, where with the current administration, things have changed quite a lot. So we heard a lot about, like really shocking disruptions to services, particularly affecting communities. So, in some cases, all of the HIV prevention work was stopped that some community organizations were doing, just things like impacting on testing, all of the important work that people were doing around treatment, all of that in some places was stopped. But despite all of that, the resilience of communities really shone through. But one thing somebody said was, stop expecting us to be resilient all the time. And, just really fund us properly, because, the work of communities is so important, and that really, really came through. But it's just like this expectation that communities will just carry on with very little in relation to resources. What's the situation that you're hearing, like in Ghana?
It's very similar, and just a lot of taking and instability, and particularly in Ghana, I think that the political response within the country has been supportive. So I know there's been many programs that the government have tried to plug the holes of, but you can't plug everything. And so the feeling of loss is felt very much across the sector. And we also have to remember that where people were starting from was not in abundance. People were starting off in deficit and then taken away. And so work that needs to be done is still there. And there's more of it. So I think, it really resonates when you say about people just being fed up with things being taken away.
Absolutely. And I mean, it's great to hear about political leadership in Ghana, because something that really came across as well was that these cuts are very much political choices. It's not an inevitability. And we really need real meaningful change so that countries are never in this situation again.
Exactly. Yeah.
But also really recognizing the importance of community leadership and how things are so much more successful when communities are leading on it or working in close partnership, but in a meaningful way, as opposed to the tokenistic tick box exercises that we've seen somehow.
Completely. And I think that rarely I try to think of situations in which bringing in the community has brought more harm than good. Is that bringing in the community on a very, very simple level supports us to do better and to respond in the way that we need to respond. But then, as you say, bringing in the community in truly meaningful ways, is only a positive, and the negatives only come when we don't do it correctly.
Absolutely. And we're seeing that in the UK with initiatives like Skin Like Mine that we're working on. But also, Vanessa, you are doing something really groundbreaking at the moment in partnership with Positive East. Can you tell us about what you're up to?
Oh, no, definitely. And I think it's one of these things that I want to always make sure that everyone involved gets their kudos, because I was doing the clinic at Positive East, but to get there was everyone working together in true collaboration. So we have to first of all thank the Elton John AIDS Foundation, who have funded the pilot, and it's been funded through Northeast London commissioners. And so we've got our commissioners across Newham, Tower Hamlets, City and Hackney, Waltham Forest, that have come together to commission some services. And within that, it's Positive East, and Barts Health, and Queen Mary University of London, and it's part of the digital PrEP as well. So digital pre-exposure prophylaxis, and that's also working with Preventex and Sexual Health London. So a whole group, large collaboration of people to essentially work with us to bring PrEP into the community. So we know that PrEP is available, it is highly effective, and it can be transformative. But it can only truly be transformative if it reaches the people that need it. And we recognize that within sexual health services, that not everyone can access the PrEP that they need, and that's for a multitude of reasons. And that's why there's a lot of work in thinking, how can we work with sexual health services face to face to build other ways that people can access PrEP. And so there is PrEP, which is available online again, which is fantastic to see within the initiative. And then we've brought PrEP into the community. So we are providing a fortnightly clinic at Positive East, in which people can come, just explain what's happening in their life. We support them in a multitude of ways and offer and provide PrEP there and then, provide blood testing, and so much more. And it's just great to provide it right in the center of the community. And so, yeah, I feel really, it always sounds a bit, to say honored, but I am very honored to be part of it and to work with such great teams.
That is absolutely amazing. Amazing. Well, shall we bring on our first guest who has things to say about PrEP and HIV prevention? Hello, Melvina.
Hi, guys. Thanks for having me.
Oh, wonderful to have you.
Wonderful to have you on.
It's, Melvina, I was going to say that it's like I said at the beginning that I know a lot about your work and have worked with you in many different capacities. So it's really exciting to have you here and to kind of bring this conversation to the forum. So thank you so much. And a lot of our work that we do is thinking about Black women and the different health experiences. But specifically, when we look at HIV amongst Black women here in the UK, what we're actually seeing in the data, what are we actually seeing in the data? What do you think we're seeing? And what is our current understanding of why we're seeing this data?
It's a really good kind of overarching question, really. The first thing that I would say is that we have made extraordinary progress in HIV in the biomedical options that are available to us. I think we have to give the credit where that is due. We've got effective treatment, we have the U=U campaigns, we have PrEP. So scientifically, we have more tools than we've ever had before. The problem that we have is that these tools are not being made available equally. And so when we look specifically at Black African communities and Black African women in particular, we see inequalities right across the clinical pathway. So from the point of testing, engaging with services, late diagnoses, access to prevention, PrEP, and engagement with services, we see that Black women are often left behind or have poorer outcomes. And I think in terms of how we explain that, we need to be quite careful. Often we reach for references to stigma, either self-stigma or community stigma. We talk about cultural differences between Black women and other groups. We talk about perhaps a lack of awareness, or even go for individual behavior. And those things do matter, but they can't be the full explanation to explain why, after decades, we continually see poorer outcomes and experiences amongst this group. And so for me, I think it's quite useful now to look upstream around people, around communities, and think about how services are designed, who they're initially designed for, and whether we're taking initial designs from one population group and applying it to Black African women or Black women in general. I'm interested in where the resources go and how they're allocated, who's represented at the decision points when those things are decided, and whether our Black women communities are actively involved through from the design of a new program or intervention right into how it's delivered. Because when communities come to seek services, we're not just responding to a health message, we're also looking at the institutions behind it, the systems behind it, whether we feel safe, whether we recognize it's a place for us there, whether we trust the services are designed with us in mind and that we will be well cared for. So I think we need to move beyond thinking about Black women as a community or thinking about behavior, and really considering where our access actually shifts and shifts that responsibility perhaps from the individual back to the system, and ask a bigger question about why we're experiencing the outcomes that we see.
Absolutely. I agree with you 100% there. And I think sometimes it can be a little bit easy just to say it's just stigma. And as you say, stigma does play an important part, but then sometimes it feels that it's just the easy way out. Occasionally a little bit reminiscent when we used to talk about communities being hard to reach, but not really thinking about the services that were inaccessible. So I think that that's a much better way of looking at that and thinking about the system, and then also thinking about all of the barriers that Black women in particularly face where it comes to health and health inequities, and the fact that this is something that we see across so many different health conditions for generations. HIV is just, one of the health inequities that Black women experience. And until there's more focus on changing the system and looking more deeply, I don't think that we're really going to be able to address that. And Melvina, we've known about these HIV inequities for years. We keep getting reports that are showing the same thing, but with very little change. What would you say is still missing between an organization recognizing an inequality and actually doing something about it?
It is a huge question, and what we'd call a wicked problem, really, because I think if it was easy to answer, we would be closer to finding out what we should do. We are very good at describing inequality. You've said that, like we produce excellent surveillance data, world-class excellent surveillance data in the UK. We disaggregate our data, we look at different groups, we publish it annually, and we present it at conferences and we discuss it. And I think this brings almost like a quiet danger in that we get used to naming and measuring a gap, and we almost feel as though we are addressing it because we're talking about it, but that's not the same thing. And so this gap between data, evidence, and action is where I think we need to do a little bit more teasing out, because nobody's health improves because their disadvantage has been counted accurately year upon year, and we've been cited in a report or a paper. So I think what's missing really is the organizational lens and that organizational readiness and capacity to act within a system that supports it. So if you imagine a commissioner, for example, gets some data showing a large inequality in PrEP access, that doesn't tell them what they should do on the Monday morning after they've received that. It doesn't necessarily land the ownership of the problem. It doesn't align with the authority and the budget to change the pathway in that trajectory. So that's the part that I'm really quite interested in. And you mentioned that HIV is just one example of an area of health where Black women are experiencing poorer outcomes. And we talk in the research world about wider determinants of health. So the other factors beyond the individual that impact their health, and that would cross not just HIV but the other areas. So if we look at our education systems, if we look at our social care systems, if we look at our environment, there are so many different factors and systems that impact Black women's ability to engage with healthcare, and we need to think about those more broadly. So maybe what we need is a kind of a wider determinants approach to thinking about organizations and our institutions and our systems, and think beyond the individual organization. Where's the ownership? Where's the responsibility? Does that institution or organization have the resources that it needs to make happen what it wants to? And I think this is something that the current HIV action plan makes quite clear. There's a named national delivery group with regional public health teams and commissioners all expected and named to feed into that. So I think ownership is a really key point in addressing this gap. Representation as well, in terms of where decisions are being made, and not just inviting communities into the conversation once decisions have provisionally been made, or just to consult. I think there's very much a need to be present at the core decision points, and then really just embedding this accountability system into the ways that we work, so that we're not relying on one or two committed individuals to drive forward change, but there's more of an expectation within the system and amongst our colleagues which supports us in doing that. So I think that's very clear that we have EDI strategies, for example, in different organizations, and that doesn't necessarily translate into that inclusive leadership and power and the capability to allocate resources and hold one another accountable so that we can implement more equitable innovation. So yeah, I'd say representation, the ownership and accountability.
So, you know, as ever, you put it so beautifully, Melvina, and that's it. There's so many things that you said in there, and I think one of the things that we've become good at naming, and I think it's really important to highlight what you've just said, because there was a point where it wasn't named, and so we needed people to do that, and that's been great. But like you say, we've come to a point sometimes that we sit in the naming, and we don't push to that next level. But then again, as you've highlighted, now knowing it, we've got to also be in places of power and affect the change. And I know that you know, many places that I work, whether it's clinically, whether it's in academia or in advocacy, that imbalance of power is so evident. But then I think that's what we need to do more, is just challenging those power dynamics. And I bring up academia because I think that is a place that there's so much need for dismantling power. And part of the work that you do that I love is about challenging what people term and what believe, or how they affect co-production. So co-production, we know it's a term that gets used a lot, abandoned a lot. If you went to, I bet you, the 10 most recent NIHR grant applications, co-production is there, it's written there. Then the question is, what does genuine co-production look like, and how do we do it well? So what are your reflections on this?
I think your discussion there on power is central to what co-production is. I think you'll find there's so many different definitions of co-production, but ultimately it's about sharing power in decision making with the people that are affected by a particular health condition or situation, and for whom meaningful influence can result in meaningful change. But we do use the term quite loosely, and co-production is different from consultation. It's different from just general engagement. I see it as a form of engagement, and a very involved form of engagement, but it's about inviting people in at the point at which they can actually make a difference, and being honest with people, and demonstrating that there's trust there. So, for example, we know that there's always going to be constraints in any kind of project, whether it's service development or research. There's going to be funding constraints, regulatory constraints, timeline constraints, but actually naming those very early on helps to engender that trust with community members. So I think trust is a really important thing, and acknowledging that it can take time and will take time to build relationships, and it's very quick to lose that trust. So we have to be very mindful that what we do in our actions, we need to understand that community members will relate that to research in general, or relate it to a service in general, or an NHS trust in general, or in fact the NHS or the health system. And we do have to be mindful about how our actions can be interpreted. I think just on interpretation there, we often bring in community members to help maybe generate material, or to review a leaflet or something like this. And this is just very peripheral, and it doesn't feel like it's using co-production to its full potential, and being able to share the interpretation process and the development process in full, and be willing to take on different views. I think from an academic perspective, we're really challenged because often we are sitting in an ivory tower, and our entire professional world is around being learned and having expertise and being the ones with the knowledge. So being able to give up some of that seat and to share this idea of being the expert, and knowing that someone with lived experience is an expert in what is happening with them, is something that can be quite difficult to do. And so adopting more of a reflexive approach and acknowledging the difficulties that we might experience in power sharing, I think is also really important. Equally, the other thing I would mention then is being able to close the loop. So
Yeah.
we invite people into the co-production process, and sometimes things can change as a result, sometimes they don't, but we don't always tell people what has changed as a result. If we're doing co-production really well, they will know because they'll be there with us. But it's really important, and it's feedback that I've gained from so many community members, is they want to know what happened with that project, what happens next. And we're challenged because our research cycles or development cycles are often fixed in timelines. So it's almost as though the project ends, so now we finished co-production, but the relationship that you have with the individual could actually live beyond that. So I do think it's important that we consider the long-term implications of our actions in co-production, and build in the method and the way of thinking quite early on in our work, and not just wait until we've decided what we're going to do and then bring in community members later.
Oh goodness, yes. No, I agree, and it's definitely something that we've seen time and time again. But it's not just academic institutions. We also see it within the charity sector, who perhaps may feel that because they're a charitable organization that makes them community, when the reality can be very different. You know, organizations are perhaps more civil society and can be very well-meaning and do really fantastic work, but their activities aren't by the community that they are trying to reach necessarily. And it's also recognizing that communities are by no means a monolith. You know, it's not good enough, for instance, having a Black woman and then thinking, you know, like, tick, you know, you are the person that represents all of community. So I think it's really important to recognize communities in all of their diversities, and also recognizing that co-production can be hard, it can be messy, it can take a little bit longer, but at the end of the day, it's so much more authentic and effective as well. But it's going to be a journey for everyone. But something that's really topical at the moment is DEI. We're seeing a lot of that at the moment in relation to academia, even before, you know, all the stuff that's been happening over the last couple of weeks. You know, we've seen a pushback against DEI in the States. Some organizations are quietly retreating from equity and inclusion commitments only made a few years ago. What would you say, Melvina, how this can impact Black women, including Black women living with HIV?
Yeah, we can see the same pattern kind of flowing over from the States. And while very few organizations will make an announcement about this retreats from equity and diversity and inclusion work, we might just see that posts are not replaced, or a specialist team gets absorbed into something broader, and then the work becomes diluted, maybe a strategy's renamed. And gradually that could change the ambitions and the intentions that were initially set. I think because much of this work is also relatively new. We could say in the last 5 years, there's been a real acceleration around DEI work. In many cases, it might not actually be embedded into the business as usual and the ways of working. So therefore, it would be easier to slip out of actions that are relatively new. I think for our community of Black women, and particularly those living with HIV, there's this issue around underservedness, and being able to be recognized and prioritized within a framework, and to continue to be visible in the data. So I know I mentioned before, it's not enough to just name the problems, but we have to name the problems as a minimum, and then we need to look to address them. And again, I think this is where something like the HIV Action Plan is really helpful, because it's explicitly recognized that Black African heterosexual women are one of the population groups that we need to intentionally track progress for, and that we need to ensure equitable access to prevention, testing and treatment and care. And so that actually runs through the plan, and we already have those targets in place. For me, it's less about the wording and the way that we describe our approach to DEI or EDI, and more about the actions that we're taking and the commitment that we're making, because these changes can happen in ripples or in splashes. So you could have a big splash of a policy or a strategy, but actually every interaction that we all engage in is either furthering or making more difficult an EDI agenda. And so we can't change what's happening on the bigger geopolitical scene, but what we can do is be mindful of our own actions and how they may be interpreted and what our intention is, and just continue to learn as individuals, even if there isn't a specific stream of work that fits into. And I think it's important just to say that we know that the landscape is continually changing, and what we need to do now is to learn how to work in these fast moving environments. We're in a very different space. The pace of change is the most rapid it's ever been to date. So we have to get used to working in an environment where perhaps the terminology is going to change, perhaps the priorities will change, but our actions and our ethos and our intentions don't have to follow.
Fantastic. I agree with you 100%. Thank you so much, Melvina. And we've actually, I just realized that we've run out of time. We're only going to be speaking to you for 10 minutes.
I was thinking it's one of these things that about revising the shape of the podcast, because it was just great to actually have the opportunity to speak more in depth as well. So
yes.
Thank you so much. It's been great.
Thank you so much for coming on.
Thank you,
Melvina. Take care. Oh my goodness. Yeah, I can't believe that we ran out of time. I'm so sorry that Yvette wasn't able to join us, but I really hope that she can on a future show.
Completely. And I, just thank you to everyone that's joined us, and a huge thank you to Dr. Melvina Woode Owusu, who gave all of her time, this half hour, but really was able to expand on so many issues that we talk about and are so relevant in what you experienced as well. And also a huge thank you to Disruptive Live for supporting the broadcast.
Yeah, and if you have enjoyed the show, do please subscribe to our YouTube channel, Phoenix Health Movement YouTube channel, to catch future episodes. And we will be back next month with the next episode. We have one amazing guest confirmed, Dr. Oni Blackstock, who will be joining us, who's absolutely amazing, and will be talking more explicitly about racism and the impact that that has on Black women's health. So join us in September for the next show. Thanks very much, everyone. Take care. Bye-bye.
Bye-bye.